Today's webinar, it's an introduction to integrative harm reduction psychotherapy. Our faculty today, his name is Dr. Andrew Tatarsky, and he will introduce himself when he starts the webinar.
It's great to be here with all of you.
Thank you. About Alive Maryland. Health HIV has partnered up with the Maryland Department of Health, which is a program that has engaged, like I said, with all us Health HIV to launch Alive. The first ever comprehensive capacity building initiative for the infectious disease and primary care workforce in the state of Maryland. Some of the services that we provide is individualized trainings and technical assistance. We provide CMEs for eligible virtual trainings and safe-paced curriculum, downloadable resources and toolkits for community partners, an integrative Maryland Department of Health training calendar, and some of the capacity building assistance and training core content areas includes an effective HIV, viral hepatitis, STIs prevention, care and treatment programs for specific populations, health equity, financial and grants management compliance, care and treatment, organizational and infrastructure development, prevention and surveillance, and ending the HIV epidemic. The speaker has nothing to disclose at this moment. And some of the educational objectives for this webinar includes identifying the psycho-biosocial multiple meanings process model of addiction, supporting IHRP, describe harm reductions for principles, explain IHRP's 7 therapeutic tasks. Is this part of your slide, Doctor?
Yes, it is.
So if you can introduce yourself, please. Thank you.
Okay, so I'm very excited to be here. I want to thank Alive Maryland and the Health HIV program for inviting me, and I want to thank all of the participants for joining to exchange about what I think is one of the most important new ideas and approaches in the field that can really improve our ability to help people across the entire continuum of care, people who are struggling with problematic drug use and other risky and addictive behaviors. My name is Andrew Tatarsky, and I am a clinical psychologist, and I've specialized in working with people that struggle with drugs and other risky and addictive behaviors for my entire career, which is over 40 years. And I've really wrestled from pretty early on in my career with the reality that as a field, we have not done a very good job of helping people that struggle with drugs. What I've come to really believe is that the dominant thinking about what we call addiction is really problematic and in many ways wrong. And it's given rise to a treatment, sort of some fundamental assumptions in most treatment that are really problematic and limit our ability to be helpful to people. And so where I've come over the course of these years is to believe more and more that we need to shift the paradigm, the way that we understand what we call addiction, from disease to what I call a psycho-biosocial process model, which I will break down. And that shift in thinking really supports a shift in our practice from what has dominated the field, which I call an abstinence-only approach to treatment, toward my work, or work that's informed by integrative harm reduction therapy. And what I'm going to do today is sort of make the case for that, talk about the clinical rationale. I'll talk about that psychobiosocial theory, and then that will set the stage for some basic definitions of what a harm reduction frame for helping people is. And then I'll introduce my model, which I model into 7 therapeutic tasks. tomorrow, I'll be giving another talk, and that will be going into those 7 therapeutic tasks in more depth. And also we'll be talking about some very specific techniques and strategies and skills that go into that. So, join me on this journey. And I invite people to throw comments into the chat, questions in the Q&A. I'll be talking for about 45 minutes, and then we'll have 10 or 15 minutes for Q&A. And I really invite people to engage with the material and take it on and see how it fits with your experience and how it might be adapted to your settings. So I really believe that we need a scientific revolution, or rather that we're in the midst of a scientific revolution in, as I said, the way that we think about what we call addiction and the way that we treat it. And here's the problem. In 2021, you folks may know, we had the greatest number of people dying from lethal overdose and drug poisoning in American history. The number was actually 108,000. And a number of different organizations, including the federal government, suggest that 100 million Americans struggle with substance use that's problematic in some way that has serious public health consequences. Only 10% of people with substance use disorder actually go to treatment. And these are government statistics. Only 42% of people actually complete treatment. So just think about that for a bit. This huge number of people that are struggling, of that number, a small percentage go to treatment, and an even smaller percentage complete treatment. I might also add that over the last 20 years, we've lost 1 million people to lethal overdose. And this is just, a catastrophic impact on our communities. Now, all of this is supported by these dominant narratives of addiction as a disease or moral weakness, which still persists, in pervasive stigma. And this abstinence-only ethos dominates our treatments, both substance use and mental health treatment. So I would suggest that we have ineffective care across the entire continuum. And this is in a context of a society dominated by stigma. Now, I'm not suggesting that the practitioners, the people that are working in the field, are not well-meaning and in many cases, doing very important, very good work, but that we need to consider that the dominant thinking has really contributed to limitations in our ability to be effective. Next slide. So what's the solution? What would that paradigm shift be? What I think of as this psychobiosocial or a rehumanized view of substance use as meaningful, even problematic substance use, and multiply meaningful to people, a meaningful response to suffering. And that this shift in thinking hopefully will lead to a social revolution in how we treat people who use drugs, from stigmatizing, punishing, removing to embracing and supporting. In fact, there's this wonderful phrase that has been promoted by an organization in Europe, support, don't punish. And I would suggest that a harm reduction frame is essential to improving our ability to help these folks. And also, of course, and we're seeing this now, we're moving toward considering treatment for people that struggle rather than incarcerating and punishing them. Next slide. So I'd like to invite you, the participants, to just begin thinking about, what are the challenges that you face in your work with people who use drugs? And I want to suggest that whether you are a person who is working in the substance use field specifically, or in the mental health field, or in other fields, HIV counseling, prevention, etc., people who struggle with drugs enter into all of our, professional practices. So what are those challenges that might come to mind? And you might throw some of them into the chat if you like. And we can check in about that at some point later. Next slide. So I want to say a few words about Valerie. This is a real person who gave me permission to talk about her story. I began working with Valerie about 7 or 8 years ago now, and she came to me reporting in our first meeting that she was injecting Dilaudid, a powerful synthetic opioid, 4 to 5 times a day, and had been doing so for several years before she came to see me. Now, she said that she loved injecting Dilaudid, although she is a mother of 2 young children. They were much younger back then. And she lived with this terror that if she was, discovered to be injecting drugs, she would risk losing her children. So it was a constant stress, pressure, fear, anxiety, shame, guilt that pervaded her life around her drug use. And yet she said that she loved injecting, and she was caught in what I have come to think of as a very powerful and painful dilemma. The dilemma, the love of the drug use on the one hand, and the threat of life-shattering consequences for her. And I would suggest that most people that struggle with drugs are caught in some version of a dilemma like this. I did some safety, certainly some kind of safety assessment, and I determined that she was not putting herself or others in clear and imminent danger, and she was motivated for therapy. She told me the only reason she came to see me was because she knew that I was a harm reduction therapist and that I would not require that she stop using. So what became the initial focus of our therapy was why did she love injecting Dilaudid so much that she was willing to put what was most important to her in her life at risk? And that really became the point of exploration, exploring that relationship to the drug. I'll come back to Valerie as we go. Please, in the next slide. So I think it's very important for us to consider the dominant narratives about people who use drugs, because we all grew up in this culture that is dominated, saturated with these narratives. We've learned them explicitly, implicitly, consciously, unconsciously, and they live within all of us, and they live within people who use drugs. And I'd like us to consider, how do these dominant narratives impact on us, those of us that may be struggling with drugs, those of us that care for people that are struggling with drugs. The dominant disease model of addiction is pervasive. This idea that addiction is a permanent, chronic, progressive disease only arrested by complete and total abstinence. That's what I learned early on in my career, and that I think still pervades. And I want to suggest that it's not scientific. It's reductionistic. It takes, the biological aspects, which are no doubt part of, a complex relationship to drugs, and it reduces them to biology. And therefore, it can become anti-meaning. That is, it can work against, being open to the meaning that drugs have in people's lives and the function, the reasons why people are using, which really can propel drug use, like in Valerie's case. The disease model can also become a self-fulfilling prophecy. That is, you think you have the disease and you think you're out of control, and it can maybe even contribute to the loss of control. There's a wonderful article by Gary Greenberg in The New Yorker called The Creation of Disease. I would suggest that you find that article, and it really talks about the history of Jelinek's proposal of the disease model and how unscientific it was. And he really goes through that in a very useful way. Now, right alongside of the disease concept, we have a culture that's soaked in stigma. Nobody wants drug treatment programs in their neighborhoods. Nobody wants people that struggle with drugs to marry their loved ones. We tend to be very punitive. I invite people to think about what are the some of the negative assumptions that come to mind when you think about the so-called addict, right? And then right alongside stigma, what was partly driven by stigma and partly drives stigma is the criminal racist model of people who use drugs. Racism was used historically. Racism and political factors were used to criminalize drugs. And the criminalization of drugs, has had a, terrible impact on communities, and particularly communities of color. Some people say the war on drugs is a war on people. So all of this then contributes to this abstinence-only ethos, and also a split between the addiction treatment world and the mental health field, where the abstinence-only ethos says that you got to commit to abstinence to be in treatment, drug treatment. And also many mental health professionals were taught you got to be abstinence to be able to benefit from mental health care. So what happens to people like Valerie, who for whatever reason are not ready, able, or willing to commit to abstinence? They're frequently kept out of care. And I would say that is really the majority of people that struggle with drugs. Next slide, please. So here are some of the realities, actually, that most people that struggle with drugs don't want to stop, are not ready to stop, at least at the point when they become concerned about their drug use. Just think about that for a minute. Like Valerie, I would say most people are not willing to stop. So that an abstinence-only approach, or the assumption that abstinence, you need to buy into abstinence in order to get into treatment, becomes a major stumbling block or barrier to care. Now, also, many people have different goals for different substances, right? They may be willing and ready to really commit to stopping the one that they consider to be most problematic, but not others. And I think most traditional abstinence-based addiction treatment requires that people commit to total abstinence. And in fact, in many cases, there are these terrible clinical decisions where somebody is on buprenorphine, which is a opioid substitution medication, and doing quite well, but smoking cannabis, and the physician denies them or discharges them from treatment, which is, from a harm reduction perspective, makes no sense. And just to sort of kind of broaden it, abstinence is not realistic for most addictive behaviors, right? Like eating, shopping, sexuality for most people, screen addictions, and so on. So next slide, please. Now, I want to normalize this because this is a question that I've asked lots and lots of groups, very large groups of people. How many folks here, and you can put it in the chat or you can just raise your hand and imagine that we can see you, believe that exercising 3 or 4 times a week is a good thing? And when I ask large groups, usually most of the hands go up. And then when I ask, how many of you are actually doing it? Most of the time, most of the hands go down. And then there's a kind of an anxious giggle that runs through, or maybe an embarrassed giggle that runs through the group. So it's interesting to think about, how do we understand that just like a complex relationship to drugs, most people have complex and conflictual relationships to exercising and to many other health-related behaviors, which we know would be good for us to do, and yet we tend not to do them. Next slide. So one way that we might understand that is this stages of change theory, trans-theoretical stages of change, which Prochaska, Norcross, and DiClemente introduced to us in their book, Changing for Good. They spoke to a large number of successful self-changers, people who made important positive change on their own. And they interviewed them to try to figure out what were the patterns. What did people go through to get to the point where they made those positive changes. And that's how they came up with this model. They found that initially people are in pre-contemplation. They're not thinking about making a change if it's not problematic for them or if they don't identify it as problematic. Once people identify something as problematic, they move into this contemplation phase where there's a lot to contemplate. You know, how is it problematic? Why is it problematic? Do I need to make a change? You know, what are the barriers to change? What are my conflicts about changing? What are my options? And once people have become real clear about the need for the change and feel motivated, there's a next pre-action stage, which is preparation. You know, how am I going to go about making this change? Inpatient, outpatient? Can I do it on my own? Do I involve my family? So the point is that there's so much work that needs to go on moving through these stages before people get to the point of being motivated and prepared to take action. And you notice that the largest part of the triangle is below action. So it seems to me that that's a way to understand where the majority of people that struggle with drugs are, and also the majority of people who know that they should be exercising and yet don't. And this is where I think we really need to meet people around non-abstinence goals and around pre-action stages of change. And that's where a harm reduction framework kind of meets people, right, on their own terms, wherever they're ready to really begin that process of positive change. Next slide. What they found is, like with exercise, next slide, please. They looked at 15 different groups of people engaging in high-risk behaviors. And they found that at any point in time, over 80% of each group, people in each group, were not ready to take action. So, you know, what we see with people that are struggling with their drug use seems to be really what all people who struggle with important changes, you know, demonstrate or grapple with. And I think it's really important for us to think about, why do we demonize, you know, and stigmatize the people that are using drugs when they're actually struggling with the same kinds of motivational conflicts that most of the rest of us struggle with? Think about that. Next slide, please. Now, here's another challenge to the disease model, and that is we now are recognizing that substance use and other risky behaviors exist on a continuum of severity, right? The disease model would suggest that once people get down to that substance use disorder or addictive place, that they can't come back. You know, there are even slogans like, you know, once you become a pickle, you can't go back to being a cucumber. But in fact, what the data is suggesting is that the majority of people who struggle moderate or stop without treatment. Stanton Peele is somebody who's written a lot about this. And many people who have had severe substance use disorders can achieve stable moderation. So those facts really challenge that notion of a permanent chronic progressive disease. And also many neuroscientists, Mark Lewis is one of them, who know a lot more about this than I do, suggest that addiction is not a disease in a medical sense, like cancer and so on. It's a complex experiential and behavioral syndrome that I'm going to suggest is really a process that reflects the interplay of biopsychosocial factors. The next slide. So if it's not a disease, what is it? Here's an alternative addiction paradigm, this rehumanized view of people who use drugs, you know, considering that drug use is meaningful. We develop meaningful relationships to drugs and other risky behaviors. Next slide. So let's consider from a multiple meanings standpoint that substance use and other risky behaviors often carry or express multiple meanings, not just one, but there may be a number of different meanings that that behavior has to people. And that these meanings are on a spectrum of awareness, so that some people really know why they're using. In Valerie's case, she knew that she loved it, but that was about all. And as we began to explore, we began to discover that there were a lot of other meanings that were out of awareness. And now we begin to think about trauma and dissociation, right? What's going on beneath the dissociated surface, right? Beneath the surface, the urge to use, the love of the experience may be the tip of a dissociated iceberg of meaning that's out of awareness. From that point of view, that problematic behavior may be like a language that people are speaking. Something's getting expressed, but it's really out of awareness. And, the disease concept says, well, that's your disease. The urge is a reflection of the disease. When we shift to meaning, I think it really opens up all sorts of possibilities. Next slide, please. So people use drugs for reasons. Let's say, let's accept it. Most people use drugs, including alcohol, for fun, for pleasure, liberation, maybe self-care, to connect with others for positive reasons. Some folks discover that that positive effect actually has a self-medicating role. It medicates anxiety, depression, overwhelming anger, trauma. Trauma symptoms can be medicated by or resolved or tamped down by various substances. Where there's trauma, there may be dissociated parts of the self. That is the rage, the grief, the sadness, the terror, that may be out of awareness because that's how trauma survivors cope, right? But those terrified parts, those enraged parts, might actually find expression. And this is what happened with Valerie when I began to do some work to help her sit still with her urges, what we call urge surfing, and then to explore into the urge. We call that unwrapping the urge. I asked her a question, what part of you loves Dilaudid? And she said, why, the traumatized part of me. She was startled. She hadn't really thought about that before. But that led to this deep exploration over 18 months of a history of early trauma that she had completely blocked out of awareness and was living on the other side of that love of Dilaudid. Now, where there's trauma, there's often also problems with self and affect regulation, emotion regulation. People can tend to feel flooded by feelings or feel dead. These are sort of two responses to trauma. And drugs help people to kind of manage these overwhelming feelings. When there's a sense of deadness, people may use substances to help themselves feel alive and feel connected. There's also a rebellion against an inner critic. Many people that struggle with drugs have very harsh inner critics, very demanding, very punitive, right? Very self-attacking. One thing that you can achieve when you're intoxicated is you can put the critic to sleep. You can get some relief from that. People also can sort of feel like their identity is integrated. They can connect with those dissociated parts. People develop identities, even if it's a negative identity. If I'm a junkie, I'm a drug user, I'm part of this tradition of romantic, poetic, creative drug users. Then there's relational meaning. Growing up, there may have been parts of me, needs, dependency, and so on that I could not express in my family safely. So I had to dissociate those parts. And as I grow up, I may find that I can actually care for those parts, care for those needs with the drug in private, outside of my relationships. And that may give rise to an interpersonal expression. Rather than expressing my needs and anger directly, I express it around using. Group membership, I can feel connected to folks, other drug users. And then pain. aging, performance, even spirituality. So this is really attempting to sort of just invite you to think about how much might be going on in that urge to use that may be out of awareness. Next slide, please. So this is a schematic, that trauma is typically dealt with through dissociation. That contributes to these deficits in self and affect regulation. It also contributes to people feeling mistrustful of others, shameful, self-hating, and all of that contributes to that vulnerability to turn to drugs in an addictive way. Next slide. So from this point of view, the addictive relationship we may consider both as expressing a lot, but disguising it, right? So that we don't see what's going on. The disease model calls that the disease. I'd like to suggest that we need to get inside of that disease and unwrap it to sort of recover. So the problem to recover those dissociated parts of the self. So the problem behavior and the urges can be like entry points for, exploring, rediscovering, and ultimately integrating those parts back into oneself and into one's relationships, which is another way to think about a recovery process or healing, growth, and positive change. So we may become very curious, as I did with Valerie, what part of you wants to do this? If that urge could speak, what might it say? There are a lot of questions that we can kind of invite people to dialogue with that part. Next slide, please. Now, that's meaning and function, but we also have to think about how these behaviors that are reinforcing, that work in some way, over time, become deeply ingrained, overlearned habits. We condition ourselves, and part of what gets conditioned is the urge, right? Stimulus, I'm anxious. Response, I have a drink. I feel better. That's the reinforcement. And over time, when I feel anxious, I want to drink. Or sometimes when I even anticipate being anxious, I want to drink. So it's not just meaning and function, it's also habit. And it occurred to me one day that urge to drink is actually an axis of change. If we can support people in identifying their urges, stopping the action around the urge, sitting with it, which we can develop a skill at with urge surfing, now all sorts of things become possible, right? We can explore we can think about consequences, we can think about positive alternatives, right, that we can wire into our behavioral repertoire. Next slide, please. The next slide is about the neuroscience, that these overlearned habits become wired into the brain through neuroplasticity, which is a way to understand why they are so hard to change. If somebody's been engaging in these behaviors for 5, 10, 15, 20 years, that's a lot of repetition. But what we gain from this model is that we can help people discover meaning. We know something about how to help people change habits, and we know about rewiring the brain. So this model, I think, gives us a lot of ways of intervening with folks that I think is much more hopeful than a disease model which you just accept, as your permanent condition. Next slide. So putting all of this together also occurs within that social context that we need to be thinking about, how living in a criminalizing, stigmatizing context also contributes to shame, guilt, anxiety, hiding, disconnection from positive relationships, right? And all of that compounds, whatever the other suffering was that was sort of related to the drug use in the first place. Next slide. So we put all of this together in this psychobiosocial model. Just consider in the upper left circle, all of those things are associated with addiction or problematic drug use. None of them cause it, right? That's why I call them vulnerabilities. But we need to consider that there's some combination of vulnerabilities that's unique for each person, right? Trauma, living under difficult life circumstances, in a low-income situation, right? Being a person of color or a member of a stigmatized group. You know, there's a whole bunch of factors that may contribute to people feeling overwhelmed and finding themselves turning to a substance to cope. So that unique fit is what we want to help folks understand and address. Now, if it's working, then over time, there's going to be chronic consequences, which does affect receptors and neurochemistry and the body and cognition. So that's going to increase suffering. And if where you go when you feel bad is toward a drug, you're likely to want to turn to that drug even more so. So what do we get from this model? I think it helps us understand, why somebody like Valerie would love Dilaudid, even while she was living with tremendous negative consequences and risks, right? So that helps us understand that dilemma of people continuing to use despite negative consequences. Another thing we get from it is we can consider that whatever factor an individual is motivated to begin working on is where we can meet them. So we don't need to require that people commit to abstinence. What if they want to work on their trauma, like Valerie? What if they want to work on their stress, a psychiatric disorder? What if they wanted to work on some of those negative consequences, right? The, physical deterioration. Whatever brings them in, motivates people to make positive change, and we can meet them there. And that's what harm reduction is all about, meeting people where they are with respect. And we can then develop collaborative relationships. Next slide, please. So now we're going to talk about the implications of harm reduction. What are the core principles? Alan Marlatt, who was a man that introduced me to harm reduction in 1994, he was a psychologist, one of the people that brought harm reduction here from Europe, called it compassionate pragmatism, which I love. We're driven by compassion to reduce suffering, us helpers. But we need to be constantly pragmatic. That is, how's it working? How are our practices, our principles, our organizational, requirements? How is it working? Our laws, and how's this particular treatment working with this particular individual? So this really speaks to a need to really radically individualize it and work collaboratively with folks. Any positive change is a phrase that most people have heard when they think about harm reduction. And here's where I think harm reduction is a powerful, dramatic shift, specifically away from abstinence only. We want to support any reduction in harm without requiring abstinence or imposing our values, our agendas on folks. So what that enables is us to create a safe space where we can invite people to reveal themselves, their vulnerability, their needs, their motivation. And we can really meet people where they are, rather than requiring that they meet us where we want them to be. And that's the fundamental basis for alliance, therapeutic alliance. We can meet them around whatever goals bring them: safer use, reduced use, moderation, abstinence, including abstinence. We can lower the threshold to wherever they're ready to begin that positive change process and really tailor to the individual. Another, I think, major principle is gradual versus quantum change. Rather than let's start with the goal of abstinence, let's start with whatever positive change a person is ready, willing, and able to take on. Maybe even just showing up and talking with us may be a huge step for somebody. So this is how change happens, in small fits and starts, one step forward, two step back, And so we're also meeting people where they are with a kind of collaborative spirit, which is inherently empowering: respect, collaboration, empathy, support, right? So we're really turning that traditional approach, which presumes to know what people need, upside down, and kind of presuming that we don't know what people need until we meet them and kind of can invite them to share themselves with us. Next slide, please. So public health, medical harm reduction, this is what most people out there think of as harm reduction. Honest drug education is a fundamental key, right, to risk reduction, kind of knowing what the risks are, knowing about drug interactions. Overdose prevention with naloxone, drug purity testing really needs to be out there because we have a poison drug supply in this country. Needle and syringe programs, provide people with syringes that actually help reduce infection. And now, luckily, in New York State and in some other places, New York City, we have the first supervised consumption sites. All of these interventions are highly evidence supported. Wherever these are available, you have reduced rates of HIV infection and other infectious disease. You have reduced illness and, saving lives. There's one mind-boggling statistic about supervised consumption sites, which is that they've been around for about 30 years in many other countries. Now in the US, millions and millions of people have injected under medical supervision. There has not been one lethal overdose. So these interventions bring people into care. Now let's consider if we can wrap or bring harm reduction therapy and counseling into these settings. We can now kind of use the medical public health intervention as a point of contact around which we can form relationships, positive healing relationships. And then we can link to other services and link to the psychotherapy and counseling that will address all of the complexity to move people toward their optimal outcomes. Next slide, please. These are the two books. Mine is on the left. Pat Denning and Jeannie Little is on the right. These are the two texts specifically on harm reduction therapy. If you're interested, we can talk a little bit about it in the Q&A. Mine is really loaded with case studies that actually bring you into what the work looks like. Pat and Jeannie's is more of a textbook. So they're really great books if you want to kind of move forward and kind of get educated. Next slide, please. So just a few words about the therapy, and then we'll have some time for Q&A. Since we started late, we'll be going over about 10 or 15 minutes. So what is my approach to harm reduction psychotherapy? I think given that my view is that what we call addiction is a process, it's a relationship, it's an experience, right? That is the reflection of this complex interplay between meaning, function, habit, neuroplasticity, social context. We need to have a therapy or a therapeutic approach that is going to bring interventions that can address all of those parts of the person, right? So we want to integrate a kind of exploratory focus on clarifying personal and relational meaning. But we also want to bring active strategies that can support people in assessing harmful behavior and promoting positive behavior change. So for those therapists out there, it's sort of psychodynamic, relational, cognitive, behavioral. And I think mindfulness, which is really about bringing present moment awareness with acceptance, can support both of those important functions. And all of this takes place in that harm reduction frame where we're meeting people wherever they're ready to begin their positive change journey on their terms. Next slide. So this is the last slide that maps the IHRP, or Integrative Harm Reduction Psychotherapy model. It's my way of trying to kind of figure out, what are the core things that we're actually doing when we're trying to be helpful to folks. And these 7 tests are not necessarily sequential. But, when I'm working with somebody, I'm thinking about sort of what's the main focus today? What are we working on today? And certainly managing the therapeutic alliance, the circle on the top, is the key. It's the foundation to everything else that takes place. If we don't have an alliance, we're not working together around shared goals and strategies and having a good bond, a good quality bond, I don't think we can do anything else. And that therapeutic alliance is forged by meeting people where they're at. If we can't meet people around their goals and their motivation, I think that the alliance can get derailed right from the start. So let's think about what are some of the challenges to the alliance. And we can talk about this tomorrow for those of you that can make it. When you're talking about folks that have experienced multiple traumas, and are really struggling with drug use and feeling quite ashamed, stigmatized, expecting to be punished, criticized, there are real challenges to that alliance. But once we have a good alliance, now a relationship builds around that alliance. And that relationship itself is a primary vehicle of healing to the extent that the drug use has relational meaning. Like just an example, I can't express my anger in my relationships. When I feel angry, I turn to a drug to stuff it, to medicate it, or even to express it in action. So to the extent that that thing is going on, if we can invite people to come into our relationships with their drug use, and then we can invite people to inquire in and talk about what might be driving the drug use and invite those feelings in, people can have this, what we call a new relational experience that can be healing for folks. Now, to the extent that there are problems with self-regulation, that is, having difficulty managing uncomfortable emotions, and that they're using the substance to kind of manage those difficult emotions, to expect them to give up the substance before they've shored up or strengthened their capacity to self-regulate is a setup for failure. So the third task is really about very specifically strengthening, supporting people in getting better at affect management, emotion management, and regulation through active strategies, mindfulness, breathing techniques, positive self-talk, even physical activity. So that's a whole area. And as people can develop the better ability to sit still with their distress, now we can focus on the fourth task, which is assessment as treatment. Really taking apart what are all those factors that are getting expressed through the drug use. The multiple meanings, the functions, the habit aspect of it, possibly trauma, which is very frequently a part of it. And then the fifth task, we move into what we call embracing ambivalence. So what that refers to is that, like with Valerie, most people that struggle with drugs are ambivalent. A part of me wants to do it, and a part of me doesn't. A part of me wants to change, a part of me doesn't. A lot of traditional treatments only want to talk to the part that wants to change. Our belief is that we need to invite both parts in, so that which have been in a battle, and instead of battling, we want to try to encourage a constructive dialogue, right, between the part that wants to use and the part that wants to change, so that we can then think about what would be positive goals, that is harm reduction goals on both sides of that ambivalence that would actually be in sync. So for Valerie, it was addressing her trauma to a certain extent. And when she felt that her trauma symptoms had really abated, she now felt very ready, motivated, and able to go to detox. Went to a detox, got off the medication, the drug, and has never looked back. 7 years later, with problematic use. So once you've got some good goals, now we can set about having a personalized plan for change. And that plan is really about how do you, work toward those important positive changes around the issues related to drug use in a way that is in sync with your positive values, so on. So at this point, why don't we get rid of the slides and let's check in with folks if you've got questions. Oh, well, this is just to say, if you visit my site, centerforoptimalliving.com, we have lots of training opportunities if people want to go into this material in a lot more depth with skills and so on. So what I've tried to give you here is a very brief overview of the clinical rationale, why we need harm reduction, how we understand why most people are not ready, willing, or able to stop, and why we need to meet them there. That harm reduction principle as a frame, and then how we might apply that with these 7 therapeutic tasks.